In Chapter 16, we will review the diseases of the digestive system. The coding principles that we have reviewed in previous chapters apply to Chapter 16 as well. It's also important for you to pay particular attention to the use of combination codes and to the many exclusion notes located within this chapter. The most common causes of GI bleeds are gastric and intestinal ulcers and diverticular disease of the intestine. The fifth digits for GI ulcers, gastritis, angiodysplasia, duodenitis, diverticulosis, and diverticulitis indicate associated hemorrhage. Codes from category 578 for gastrointestinal hemorrhage are not assigned when codes for bleeding of any of the sites mentioned above are available. This category is acceptable only when the physician's diagnostic statement clearly states that the bleeding is due to another condition. If the physician documents a clinical diagnosis of GI bleeding based on the history or other evidence, the fact that no bleeding occurs during the episode of care does not preclude the assignment of a code that mentions hemorrhage or a code from category 578 when the cause of the bleeding cannot be determined. Carefully review the inclusion terms in the digestive chapter, since some digestive system codes will include hemorrhage or gastrointestinal bleeding, and therefore the GI bleeding would not be coded separately. For example, if the physician listed GI bleeding due to acute ischemic colitis, only code 557.0 for acute vascular insufficiency of the intestine. Hemorrhage is included in the inclusion term under code 557.0. Combination codes for hemorrhage should not be assigned unless the physician indicates a causal relationship. If the documentation provides more specific information and the bleeding is linked to a specific condition, assign the appropriate combination code with the bleeding. It's important to remember the physician must identify the source of the bleeding and link the clinical finding from the endoscopy, since the finding may not be related to the bleeding. If hemorrhoids are incidental findings and unrelated to the rectal bleeding, assign code 569.3, hemorrhage of rectum, followed by codes for hemorrhoids without mention of complication. Do not assign a combination code for hemorrhoids with bleeding unless the physician explicitly states a causal relationship. And you see here two examples of 455.2 and 455.5 as the first listed and as a secondary diagnosis. When we look at category 530 for diseases of the esophagus, you'll see that it includes acute esophagitis, reflux esophagitis, ulcers of the esophagus without bleeding and with bleeding, dyskinesia of the esophagus. These are all important diagnoses for you to be aware of. Esophageal varices are coded to the circulatory system and are coded as follows. Esophageal varices with bleeding goes to 456.0, and esophageal varices without bleeding goes to 456.1. Esophageal varices associated with cirrhosis of the liver or portal hypertension requires dual coding with the underlying condition coded first. So for example, bleeding esophageal varices with cirrhosis of the liver would be coded to 571.5 and an additional code of 456.20. Or bleeding esophageal varices in portal hypertension is coded to 572.3 and 456.20. therapy of esophageal varices consists primarily of ligation, which is coded to code 4291, or endoscopic injection of a sclerosing agent, code 42.33. There are diagnostic tests which include esophageal mobility studies, and these are classified to code 89.32. Esophageal manometry, a test that is performed to rule out motor dysfunction of the esophagus. There's also code 89.39, other non-operative measures, and this is assigned to determine the pH esophageal monitoring test. For ulcers of the stomach and small intestines, there are combination codes for gastric, gastroduodenal, and duodenal ulcers that indicate whether there is associated bleeding, associated perforation, or both. The fifth-digit subclassification indicates the presence or absence of an obstruction that limits the ability of food or fluid to pass through the outlet of the stomach or intestinal lumen. Ulcers of the stomach and small intestine are often described as peptic without any further identification of the site. You should review the medical record carefully for any indication of the specific site involved. Dilophoid lesions are a rare cause of major gastrointestinal bleeding. When present with gastrointestinal bleeding, do not code the GI bleed separately. There are complications of an esophagostomy and a gastrostomy that you need to be aware of. Examples would be an infection, and you would use code 530.86 with an additional code to show the specific infection, or mechanical complications such as a malfunction, which would be coded to 530.87 for esophagostomy, or 536.42 for the mechanical complication. It's really important to remember with your infections to code also the specific type of infection and the responsible organism. Complications of a colonostomy or an enterostomy procedure are coded to category or code 569.6 with the applicable fifth digit. Do not assign codes from the postoperative complications category 996 to 999. Diverticulum is a small pouch or sac opening from a tubular or saccular organ, such as the esophagus, the intestine, or the urinary bladder. Diverticulosis is having one or more diverticula of a designated site. It's important to distinguish those from diverticulitis, which is the inflammation of a diverticula, and it assumes the presence of a diverticula. Assign only the code for diverticulitis as indicated in the alphabetical index, even when both conditions are mentioned in the physician's diagnostic statement. ICD-9-CM assumes diverticulosis, not otherwise specified, to be a condition of the colon, so be very careful when you're coding. Diverticula may be either acquired or congenital. For certain sites, ICD-9-CM assumes that the condition is congenital unless otherwise specified. In other sites, the presumption is that the diverticula is acquired. For example, diverticula of the colon are assumed to be acquired unless specified as congenital, but diverticula of the esophagus is assumed to be congenital unless otherwise specified. There are combination codes that are available for cholecystitis, cholelithiasis, and choledocholithiasis. And this allows us to report these conditions with one single code. So you need to be very careful when you're coding conditions on diseases of the biliary system. Cholesterolosis is a condition characterized by abnormal deposits of cholesterol and other lipids in the lining of the gallbladder. In its diffuse form, it is known as strawberry gallbladder. Diagnosis is usually made on the basis of tissue examination and is ordinarily an incidental finding without clinical significance. It should not be coded when there are other gallbladder pathology present. It's important to know that a cholecystectomy may be total or partial, and it may be performed as an open or a laparoscopic procedure. You must read the operative report to determine if other procedures may have been done during that operative episode, such as exploration of the bile ducts and intraoperative cholangiogram. If the operative report states incision of the cystic duct, this would not be coded separately because it is included in the basic procedure code. Sometimes after a patient has had a cholecystectomy, they may develop a condition called post-cholecystectomy syndrome, coded to 576.0. This is a condition in which the symptoms suggestive of a biliary tract disease either persists or develops following a cholecystectomy, with no demonstrable cause or abnormality found on workup. A postoperative complication code from 996 to 999 is not assigned with code 576.0. When there are gallbladder stones or biliary stones, it's important to know that they're removed in several ways. One is through a cholecystectomy, which automatically removes the stones, or cholecystotomy, which is the removal of the stones without removal of the gallbladder. Stones in the common bile duct can be removed percutaneously or endoscopically or in conjunction with a cholecystectomy by common bile duct exploration. So it's very important that you review the operative report to determine how those are removed. Intestinal and peritoneal adhesions are classified to category 568.0. Code 560.81 is for adhesions when there is no documentation to support obstruction. Minor adhesions easily lysed as part of another procedure should not be assigned a code for the diagnosis or for the lysed procedure. Coders should not code adhesions or lysis based solely on the mention of the adhesions or lysis in an op report. If you are in doubt, you should query the physician. Codes for adhesions and lysis of adhesions may be reported when there is a strong band of adhesions causing obstruction that prevents the surgeon from gaining access to the organ to be removed, and a surgical lysis is required before the operation can proceed. Documentation of clinical significance by the physician may include, but is not limited to, the following language: numerous adhesions requiring a long time to lysis, extensive adhesions requiring tedious lysis, extensive lysis, or so forth. So basic rule: do not code adhesions or lysis of solely based on the mention of the adhesions or lysis in an operative report. Again, when in doubt, you need to query that physician. Hernias of the abdominal cavity are classified by type and site. Combination codes are used to indicate any associated gangrene or obstruction. With inguinal and femoral hernias, a fifth-digit subclassification indicates whether the hernia is unilateral or bilateral and whether it is specified as recurrent. That is, whether or not it's been repaired during a previous surgery. Incisional ventral hernia is classified as recurrent. Hernias described as incarcerated or strangulated are classified as obstructive. Hernia repair can be performed through a laparoscope or through a traditional open approach. Use care to determine if there is bilateral or unilateral hernia repair. Repair of inguinal hernias is further subdivided according to whether the hernia is direct or indirect, or even though the diagnosis does not make this distinction. A direct hernia is one with protrusion through the abdominal wall. An indirect hernia protrudes through the inguinal ring only. Hernia repair codes also make a distinction between simple repairs and repairs with a graft or prosthesis, such as a mesh, to reinforce the repair. In coding repair of a diaphragmatic or esophageal or hiatal hernia, the access for the code depends on whether an abdominal or thoracic approach is used. Coding examples include repair of unilateral direct inguinal hernia, code 53.01, laparoscopic repair of a unilateral direct inguinal hernia with mesh prosthesis, code 17.11, or repair of bilateral indirect inguinal hernias, code 53.12. Category 540 for acute appendicitis uses a fourth digit to indicate the presence of either generalized peritonitis or a peritoneal abscess. Category 541, appendicitis unqualified, is a vague term and code that should not be used in an acute care facility. It's important to remember that occasionally an appendix may rupture during that appendectomy, and if this is the situation or the case, you would not code that as a complication of surgery. An incidental appendectomy is used when the appendix is removed as a routine prophylactic measure in the course of other abdominal surgery. It should not be assigned when there is a diagnosis of significant appendiceal pathology. So you need to be careful with that code. 47.0 is for an appendectomy. Code 47.1 is an incidental appendectomy. A code from category 001 to 008 is assigned for infectious diarrhea when the organism has been identified. Code 009.2 is assigned for infectious diarrhea not otherwise specified or described as dysenteric diarrhea or epidemic diarrhea. Code 009.3 is used for diarrhea presumed to be of an infectious origin, but it does not apply in the United States and would only be assigned on the basis of a physician-specific statement. Check the alphabetical index carefully. Diarrhea can be related to a variety of conditions. Note that the main term for diarrhea is followed by a long list of non-essential modifiers. The slow transit of stool results in a delay of transit fecal material through the colon secondary to a smooth muscle. Outlet dysfunction constipation results from difficulty evacuating the rectum during attempts at defecation. Intussusception is primarily a disease of young children and is the prolapse of one part of the intestine into the lumen of an immediately adjacent part, resulting in an intestinal obstruction. And I used to always tell my students, think of it as when you roll your socks and you roll one part over to another. It's very similar to the effect of an intussusception. Bariatric surgery consists of procedures performed on morbidly obese patients for the purpose of weight loss when other methods have failed. There are two types. Malabsorption procedures are the most common, and these procedures restrict food intake and the amount of calories and nutrients that the body absorbs. Restrictive operations restrict the food intake, but they do not interfere with the normal digestive system. A Roignet gastric bypass procedure, code 44.39, creates a small stomach pouch to restrict food intake. The Y-shaped section of the small intestine is attached to the pouch to allow food to bypass the lower stomach, the duodenum, and the first portion of the duodenum. Biliopancreatic diversion, known as BPD, is an excision of a part of the stomach to create a small pouch. Food empties from the pouch past the pyloric valve and into the duodenum and the last segments of the small intestine. In contrast to the Rouillet surgery, the pyloric valve remains a part of the digestive process so that dumping is eliminated. Duodenal switch procedures is another type of biliopancreatic diversion. The outer margin of the stomach is removed, leaving a sleeve of stomach with the pylorus and the beginning of the duodenum at its end. The duodenum is divided so that the pancreatic and biliary drainage is bypassed. The near end alimentary limb is attached to the beginning of the duodenum, while the common limb is created in the same way as the BBD. Codes 43.89, other partial gastrectomy, 45.51, isolation of segment of a small intestine, and 4591, a small to small intestinal anastomosis. And here's some examples of restrictive operations, then referred to as gastroplasties. They may be done as laparoscopic. We hear of people having vertical bands done. So these are the different types of restrictive operations. Gastric bands may require periodic adjustments, and these are coded to encounter two codes. So code F53.51, fitting and adjustment of a gastric lap band as the principal, or code 45.86, bariatric surgery status, may be reported as an additional code. There are complications that may occur with bariatric procedures, such as infections, going to code 539.01 or 593.81, depending on the type of procedure. You may see abscess or cellulitis of the abdomen, even septicemia. So if you have an infection, it's important to also identify the organism that's involved. And then occasionally, patients ask to have or need to have the restrictive device removed, and there is a code 44.97, laparoscopic removal of the gastric restrictive device. And that's the end of chapter 16.